No more Katie, instead we have Sharon Manson. You are a registered nurse, a nurse practitioner, the director of Hematology, Oncology Nursing at Rush University Medical Center. I may have that a little bit wrong.
No, you are absolutely correct.
And you've been helping people like me get through cancer for about 30 years.
Yes, I have. So you're giving away my age now.
Well, you know, the fact that you were able to graduate from nursing school at age 8 or 10, I think
That's correct.
is a tribute to you. So let's just talk about the side effects, because as patients, you know, before we go for our treatments, we dread it. We're worried about the side effects of the chemo or the radiation or the radioimmunotherapy, whatever treatment we're going through. And most of these treatments do have side effects. And sometimes the fear of them is actually worse, but sometimes you have some challenges
Absolutely.
to get through. And that's where you come in, because it's not like the old days. We've got, for every side effect, we've got some ways to minimize the side effect and to sometimes eliminate it.
Absolutely.
So let's just go through some of the common side effects. You know, gastrointestinal issues, everything from nausea, diarrhea, constipation, upset stomach. Tell us about some of the ways patients can cope with that.
Okay. First of all, just to identify that there have been a lot of changes over the last 20, 30 years. And I think a lot of people are very frightened when they first get diagnosed with cancer because they've always heard about people who receive chemotherapy and threw up constantly through it. And that's really not the case any longer. One thing to understand is that a lot of the side effects of chemotherapy occur because the different tissues in our body that are fastly dividing are very sensitive to the effects of chemotherapy, and it's not exclusive to just the tumor. The GI tract, which is anything from the mouth all the way through the stomach, the intestines to the rectum, are all parts of the GI tract and are very sensitive to the chemotherapy side effects, or radiation for that matter. So we do a lot of work prophylactically or preventatively to prevent nausea and vomiting from occurring. That's probably the biggest concern people have. We have a number of different medications that combat that nausea and vomiting, and they're coming from different classes of drugs. So in the olden days, we used to have one type of drug we can give patients, but now we have drugs that fall into different classifications, and we can combine these and have much better control of the nausea. One thing that we know that's really important is it's much easier to prevent nausea than it is to treat it. So when you start your treatment, your nurse and or your physician, assistant, nurse practitioner, doctor are going to sit down and give you a recommendation for a regimen to take. And sometimes what we hear is patients go home and they say, I didn't feel bad, so I didn't take those pills. And then they get behind the 8 ball and the nausea starts, and then you take a pill and you can't keep the pill down. So it's very important to take those medications as they're recommended to prevent the nausea. There are other aspects of nausea that some patients notice, which are called anticipatory nausea, which means you're getting ready for your next visit, you're getting ready to get in the car to go, and all of a sudden your stomach is upset, you start feeling sick. Those we treat with different types of medications, so it's important to share that information with your healthcare team.
It's funny because I'm the first person when I was going to the oncologist for the first time, so I wasn't even going to get treatment. I was just going to evaluate. I was nauseous on the way there, and Charlene said, you know, that's just not possible because you haven't even started your treatments yet. But there is that psychological aspect, and as a patient or a caregiver, remember there are multiple medication choices. So if something's not working for you, if you're having problems, get on the phone, because there are other medicines, or maybe they change the way you take them a little bit. So you really can do some things to at least minimize what I'll call the punishment.
Right.
And of course, blood counts are a major issue. A lot of times they go down during the process. There are different things, including now shots, Neupogen, other things that can boost your counts. One of the things that's a side effect, at least for some forms of treatment, is neuropathy. Could you explain that a little bit?
Yes, neuropathy is some damage to the smaller blood or smaller nerve vessels that can be found in the body. And this doesn't happen with every chemotherapy, but certain chemotherapy agents have a tendency to do this. One drug particular called vincristine or Velcade is another drug that can cause these. The symptoms that patients may recognize is difficulty buttoning their shirts or fine motor skills. They may experience numbness in their hands or their feet. Some people complain of a burning pain. Again, very important to communicate with the team. Sometimes it requires us to make adjustments to the chemotherapy doses to prevent more prolonged, permanent damage that can occur. Many of these things, as long as we know about them early, we can control the side effects of them.
And many of these side effects are just temporary. In fact, most of them are just temporary. So when you're going through what I call the dog days of chemotherapy, it's important to keep that in mind. You may look, your hair may be falling out, you may have moon face if you're on a steroid, you may have a bunch of things and not feel good or not look your usual self, but most of that stuff is just temporary.
That's true.
And we have a caller. Sylvia, if you're there, you're on the air.
Hello?
Hi, Sylvia. How are you?
I'm doing very well, thank you. So I've been watching the show, and I had a question about something you were discussing earlier as far as nausea is concerned. I typically hear about people who've been diagnosed with cancer suffering with nausea. So I was curious to know if that is the treatment that is making them nauseous or the cancer itself that makes people nauseous.
That's a great question. And I think the answer is it's usually the treatment.
That's correct. Usually the treatment is the cause of the nausea and vomiting. However, there are some times in which, depending upon the location of tumors, the tumors may be compressing on the abdomen or maybe impacting some chemicals that are released to the brain. And sometimes in those situations, the treatment actually improves the nausea as you go along. But more times than not, it's the treatment that is contributing to the nausea and vomiting.
And there's this whole other group of side effects that I'll call generally infusion reactions. Could you explain what they are?
So we lump a whole group of reactions together that occur during the administration of the intravenous chemotherapy. Those are broadly called infusion reactions. Some of those reactions are allergic in nature and actually occur as a result of an allergic reaction to some of the products. In those situations, we're monitoring the patient for signs of hives or itching or rash or difficulty breathing. And again, there's medications we can administer to block that allergic reaction. There's another group of reactions that may not be associated with an allergy but have similar symptoms. And in those situations, it's sometimes a good news scenario that as we give agents that start to destroy the tumor cells, substances are released into the blood that may cause a reaction, such as fever, chills, shaking. And in those situations, again, blood pressure may go down, and the nursing staff is usually monitoring the patient very closely. At Rush, we have a very close monitoring system for identifying those situations and handling them very quickly. So infusion reactions are a big thing. The other thing that we wanted to talk a little bit about associated with that is how the drugs are actually administered and the type of IV lines. The chemotherapy agents, some of them may be very toxic to the tissues, and if they leak out of the vein when they're being administered, can actually cause severe damage. That group of chemotherapy agents are called vesicants. There are other drugs that are called irritants, which will cause some irritation but no significant damage to the tissues.
And so you've brought some demonstration
I
materials.
have. I've brought some show and tell items here.
And we've been dying to get to these since the beginning of the program, so we'll put them out here. And why don't you just go
Talk
ahead
about
and...
these a little.
Yes.
So the chemotherapy can be administered through a traditional IV that's placed in the arm. And the staff may recommend an alternative way of administering these based upon the type of drug that you're receiving, or by looking at the patient's veins and determining that the veins will not tolerate some of the more aggressive treatments that we need to give. In that case, they may recommend a different type of catheter. And I have 3 catheters here to show you. The first one is called a PICC catheter, which stands for a peripherally inserted central catheter. This is usually put in the crevice around the bend of the arm, and this catheter can stay in for several weeks to several months. And once this catheter is placed, it's usually done in a radiology suite or by a specially trained nurse. This catheter can be used to administer chemotherapy or sometimes to draw blood from without having to put IVs in the arm. And this is an advantage. This catheter does require you to take care of it by flushing it every day. Now,
Flushing it by water or saline?
yes, some sterile saline with usually a little bit of heparin in it to keep the catheter patent. We have two other catheters that are visible here in our model, whose name is Chester Chest. And Chester Chest, the catheter that you can see that's visible, although the coloring is probably not going to show up real well, is called a central catheter that is a tunneled catheter. This has been commonly called a Hickman line because Hickman was the first brand of catheter that was used. This catheter is placed and is often used for patients who are having a bone marrow transplant or who have leukemia or need frequent transfusions, infusions, and have low platelet count, so we don't worry about bleeding at all because there's no needle insertions. This is hidden underneath the clothing, has a dressing on, and can be kept in for years if necessary. The last catheter we have is called a portacath, and a portacath is totally implanted underneath the skin. And so to remove this model's skin, you can see that it's a little round disc that's placed in the patient's chest. It's totally hidden. The nurses are able to palpate, feel for the portion of that port, and they insert a needle through the skin into this little round disc. So the advantage is it's very easy to find. There's no sort of digging to get into a regular IV. Once this is inserted, this catheter, again, all the IV tubings are attached. This port, usually the nurse will remove this special needle before you leave the clinic, and you don't have to do anything with it. And again, this can be kept in for several years.
And so the key is not only do you avoid the skin irritation or damage, but you don't have to, every time you go for a treatment, go through the whole process. It's in there, but the thing that you have to do is keep it clean. We got to avoid infection.
And people worry about these catheters a lot, and I always tell people probably the first thing I would do if I had to go through a lot of these treatments is to get one, because I know it saves a lot of a lot of discomfort and fear for people who have to have IVs placed and repeated blood draws.
Okay, well, excellent. And one more thing real quickly you wanted to show?
No, I think basically just to show you that once these catheters are in place, to have blood drawn, this is just screwed on to the end. The clamp is opened up, and this will actually allow us to draw the patient's blood right through here, and we don't need to do any needle insertions.
Okay. Well, it's always interesting when you can not only sort of get an explanation, but see exactly what you're dealing with. And Sharon, we thank you so much for joining us on Battling and Beating Cancer today.
Thank you.
And we thank Katie as well. And ladies and gentlemen, next Wednesday night, we have Dr. Seth Corey from Children's Memorial Hospital. And our subject is going to be children and blood cancer. So until then, for Charlene, this is Scott Seaman. Thank you for joining us. Good night, everybody.